people hear me? I'm trying to get this going. All right, everyone hear me in the back? We're afraid that the session is not going to be full. So thank you for everyone who's come, and thank you so much to Dr. Johnson for letting me have some of his time. I was actually going to come here to learn, but I guess I'm going to have to pay for my lunch first by entertaining you for a little bit. So I'm a neurologist, so which means that I treat patients with vestibular syndromes, and I'm at that stage in my career now where the wait time to see me is so long that everyone who sees me is now a really critically ill patient. So it's been really nice to be able to expand the therapeutic options for patients, at least in our area, by incorporating NUCCA. This idea that vein problems can cause neurological symptoms, outside of, an outright clot, is a pretty new idea. So let me just, give you my disclosure from a professional standpoint is that you're not going to meet a lot of neurologists who are who really talk about the nervous system and the impacts of the venous system on the nervous system, in this way. So, 5 years down the line, I think you're going to have to decide whether, I'm a pioneer or a crackpot, right? Because it kind of just depends on, how history, writes the story. So what I'd like to do is to talk about a little bit about the background of the venous system and why we really should be considering problems in the venous system when we think about neurological syndromes, so that we can think of patients again in that sort of holistic way. And one of the things that we're learning more and more is that problems that have symptoms in the head don't necessarily have problems that originate in the head. And we're learning more about problems, for example, in the pelvis even, that can cause problems with intracranial pressure regulation and things like that. So, humans have to adapt, we have to be flexible and not dogmatic, always, if you want to be the smartest person in the room, you have to be very comfortable being the dumbest person in the room. And that's, if I can think of one thing that I've done in my career that has allowed me to, be where I am, it's being comfortable being the dumbest person in the room. And once you become the smartest person in the room, of course, you have to switch rooms, right? So that's where we all kind of want to go in our careers. I don't have any financial disclosures, but I will be talking about non-FDA approved medications. We're using neurotoxin in the neck because we'll be using it to treat dizziness and headache rather than typical problems in the neck. So the roadmap is pretty simple. I want to give you a little bit of background about the physiology of the venous system so that you can understand why we are kind of doing what we do. I'll talk about 3 venous compression cases, kind of 2 short ones and 1 long one. These are not like NUCCA save the day kind of stories, but they are kind of rich stories in a way that will help you to see why we have the kind of algorithm that we do and why patients might have the symptoms that they do because of these vein conditions. We'll talk about vein pathology models, and then I'll tell you what I do at the university. Okay, so the physiology of the venous system. As you know, the vascular system is made up of basically 2 kind of parallel networks of blood vessels, arteries and veins, and there's the third system that we are not talking about right now, but which is super important, which is the lymphatic system. So I hope in maybe 5 years or so, somebody will be here talking about the lymphatic system. But one thing that's different about the arterial system is that it has the advantage of a pump, right, on the front end that gets to accelerate the blood and give it kinetic energy. The venous system has a much more difficult problem with pushing blood through because pressure in the veins is much more dependent on hydrostatic forces. So this is sort of like hollow water, type effects. And so this means that vein pressure is very much dependent on gravity and on body position. The pressure is lowest at the highest point and it's highest at the lowest point. So this position dependency kind of makes blood return a little bit of a problem because there's no pump at the other end. So the venous system actually has to be a little bit smarter in some ways than the arterial system. So this is is a very basic vascular unit. You know, the blood goes, you know, to the heart, it is oxygenated by the lungs, gets pumped out by the arteries, which sends it to the tissues that use up the oxygen, gets the metabolic waste, and sends it to the veins and back to the heart again. And again, you won't forget the lymphatic system, which is really important in picking up all of the rest of that metabolic waste and volume in the tissues. Now, it has only been since 2012 that we have acknowledged that there is a lymphatic system of the brain. And for the longest time, you know, like when I went to medical school, we just said, well, there is no lymphatic system of the brain because the brain is an immunologically privileged organ, right? And of course, the reason why we didn't think that there was a lymphatic system of the brain is that if you slice the brain and try to put it on the slide, those empty spaces were the lymphatic system, right? So it's like there's nothing, you know, put there. But it's turned out that that is an incredibly important system for the clearance of metabolic waste, and it becomes really important when we're talking about symptoms that we kind of give abstract diagnoses to, right? Like chronic fatigue, right? And it's probably also going to be really important in things like neurodegenerative disorders that have to do with protein deposition, right? And that lymphatic system of the brain is also connected to the lymphatic system of the body, and it's intimately related to venous drainage. Now, most of the attention, at least on the medical side, has been on this part of the circuit, which is the cardiopulmonary arterial part, because, you know, people die, right, from cardiopulmonary, you know, arterial disease, and they die very quickly. And so when I talk to residents about, you should pay attention to veins, when someone comes in with vertigo and a headache to the hospital, I don't want them to think about veins, I want them to think about heart attacks and strokes, right? Because those are the things where you do not have the luxury of time to figure this stuff out. So where these venous problems become really important are patients with really chronic symptoms, right? These are the people who are having symptoms for months or years, and there's no like physiologic model that seems to, fit them. And so I think this is where we can actually grow quite a bit, not only in our kind of knowledge, but our treatment options for patients. So the venous system is known as the capacitance system of this circuitry because it's the side that can expand and contract based on the body's sort of physiological changes. So this means that things like hydration status changes, food intake, ambient temperature, barometric pressure, activity level, body position, body weight, body size, all these variables that we have to constantly sort of adapt to in the environment, they're absorbed on this part of the equation, right? It's sort of like an oscillation dampener, in a way. The arterial system is the resistance system because the job of the arterial system is to generate perfusion pressure, right? So the arteries, have the advantage of the heart, giving kinetic energy, but they also squeeze to raise pressure, and that's how you push blood, through the capillary beds. This volume and pressure on the arterial side, it's protected at almost all costs, right? It's like the last thing that's going to go. And the pressure only drops if you're severely dehydrated or if you have autonomic dysfunction or you have severe problems with the pump. So an important piece of this kind of puzzle with the circuitry is that this vascular system does not exist like in its own protected space. It exists within the musculoskeletal system, right? And when this system is sort of embedded in muscles and bones, arteries are going to mostly do okay because they are under high pressure with muscular walls. The veins, it's a little bit of a different story because they are under low pressure. We're talking about pressures that can even be negative, right? So while arteries are generally only bothered by bones, right, veins can actually be compressed by bones, arteries, and also muscle. So now the question is, if you are a blood cell in the vein, right, and you are, in this situation of being under low pressure, how do you get back to the heart, right? So it's mainly through these, five forces, and I'll only cover them briefly because I know when, you're doing these adjustments that you're kind of focused on one part of, this axis, but the effect that you have can actually be in many parts of the body, right? So, the first way that blood gets back, to the heart is by gravity. This is intuitive, but it is not straightforward because the way that blood gets back, even in relation to gravity, is dependent on the position of valves and in relation to where there are points of high resistance. And so, there are some patients who cannot stand up. There's also patients who cannot lie down, because of these vein compression problems. Patients will say, I can only sleep at a 45-degree angle because I get vertigo in one direction, syncopated in the other direction. The other important component of venous repair is just muscle contractions, right, in your legs that are working on one-way valve. So when your particular calf muscles are squeezing, it raises pressure, these deep veins, so the blood goes in one direction, but it can't go backwards because the valve's only closed in one direction. Just the pumping of the heart, lowering right atrial pressure allows blood to flow in from the inferior and superior vena cavas. A pump that people don't really think of as a pump is actually respiration. So respiration is a kind of pump. When you take a deep breath, the abdominal pressure goes up, your intrathoracic pressure goes down. Now you create a pressure gradient to now sort of suck blood back into the chest. And then there's also just riding the wave of arterial pressure through the capillary beds. And your body is really, the body is very clever in some ways and very unwise in other ways. But when blood gets to the venous side of the equation, there's still a little pressure there. And as blood volume increases because the veins sort of coalesce and they become bigger veins, the cross-sectional area goes down, but the volume goes up, so actually the pressure goes up. And so there's sort of a natural kind of flow of blood going back into larger muscles. What's really interesting, and this was work by somebody, Paolo Zamboni, who's in Italy, and he's got kind of interesting reputation in neurology because in the 2000s, he started to say that a lot of neurological disorders like multiple sclerosis were actually due to these vein compression problems. So he was trying to treat multiple sclerosis by treating veins. So I think he was kind of on the right track, but maybe not seeing the entire picture. But he did some really beautiful venopathy studies that showed that although blood in the veins should all flow towards the heart, so down if you're above the heart and up if you're below the heart, if you start having these compressions, the blood can actually go in non-physiological directions, right? So for example, in the internal jugular vein here, the blood can go up, right? Or in the hemiazygous and azygous veins, they can cross up and down below the heart, or you'll have phenomena like this where the paravertebral venous plexus around the spinal cord, that's become your venous sink, right? And so now you start having a lot of spine issues in things like back pain and alterations in intracranial pressure because of the abnormal stenting of this blood. And so you say, well, so what, and how could this happen? These are pretty big systems. I just want to give you one kind of example of how large bodies of water can actually change flow. So, the largest river in the world by volume is the Amazon River. It flows in the northeast direction. It's only done so in the last 10 million years, right? So 65 million years ago, it actually flowed in exactly the opposite direction. And you can kind of figure this out by where mineral deposits are and where lakes are and stuff in South America. So what happened? Right? What happened in South America? Well, so the Andes Mountains started to rise about 65 million years ago. And as the Andes Mountains started to go higher and higher, the flow started to go downwards. And so, a large body of water can change direction, right? So one of the most important needs of our generation, right? Just time and pressure, right? And this time and pressure change on these venous systems can happen sort of under your nose. And they might not even be symptomatic for a long time because you are compensating until that kind of last event that can often seem very minor. Like a minor fender bender, or maybe you just had a little viral illness, or maybe you had a vaccine or something. And something is so the patient will start having like disproportionately severe symptoms for whatever they attribute the trigger to be. So just kind of think about all the stuff that can happen sort of under the hood and be relatively asymptomatic until that last transition point. So these vein compressions can happen all over the body, and we're appreciating them more around the heart and the abdomen. But we're going to focus on the internal jugular vein. There are three parts to the internal jugular vein. part that is right at the skull base that we're mostly interested in. This part in the middle of the vein that a colleague of mine at Abbott Northwestern, a vascular surgeon, and I are very interested in this syndrome, which is that the internal jugular vein can actually be trapped under the sternocleidomastoid muscle in the middle of the neck. So this is a second point of compression. And the third point is at the base of the neck where it joins with the subclavian vein of the thoracic outlet. So I'm not going to talk about thoracic outlet syndrome so much, but I just want you to kind of just know that this thoracic outlet part of the story is incredibly important to the story, because the subclavian vein is not just some like dumb arm vein that you only worry about in like arm symptoms. It receives the external jugular vein, which is the kind of the partner to the internal jugular vein, draining blood from the head. And it also receives blood from the vertebral veins that drain the spinal cord, right? And so people who have subclavian vein compression may not have all of the neurogenic symptoms of neurogenic thoracic outlet syndrome. But I think it's really important when we talk about the thoracic outlet syndrome that we don't kind of just slice the body this way and then give this all to the orthopedic surgeons and the vascular surgeons that just slice the body this way, and so that maybe some of these structures kind of belong to neurologists and neurosurgeons, et cetera, right? So what entities can cause problems at these locations? So we talked about the compression of the internal jugular vein by the combination of the styloid process, the lateral process of C1, and a really important muscle called the posterior deltoid of the digastric muscle. And some people have compression of this internal jugular vein just by the muscle. So it's important that when patients are being evaluated that you look for all three components. The second is this muscle complex that's made by the sternocleidomastoid or omohyoid muscle. This has it's been a really exciting area, but it's kind of, sometimes you think, oh, it's like 2024, why isn't the world figuring this out yet? Why did it take us all the way until now? But the omohyoid is actually fused with the carotid sheath, and it's thought that the contraction of this muscle is actually really important in the dilation of the carotid sheath and in the regulation of intracranial pressure. And so I'll talk a little bit more about this relationship with the third case. And then, of course, the last part is this thoracic outlet and the compression that's induced by the anterior scalene muscle. So in neurology, we think of problems sort of in the head and outside the head, whereas we think of intracranial and extracranial problems. But when it comes to the venous system, this is actually one system, because the valves that prevent the backward flow of blood don't happen until right at the level of the clavicle, right? So from the standpoint of this like massively parallel sort of passive system, the head and the neck are actually one entity, right? And so, this parallelness and all that, it's all really great because blood can go left to right and, right and wherever, except the problem is that the head is attached to the neck, right? And so, sometimes you think like, if I were whoever designs the human body, would I have designed it in this way? I often think about this, right? And so, it's nice that you need enough to move your head around, but this is also where you have a lot of freedom of movement and where you have a lot of vulnerability to injury, right? And, we have a decade of the brain in the 90s, and it was really good. We talked about stroke symptoms and heart attack symptoms and stuff like that, but it's kind of time to think about the decade of the neck, right? All right. So Dr. Johnson was alluding to, about this positional nature of venous outflow from the head. This is really, really intriguing, and we should really think about this in patients who have positional symptoms. So this is actually a study done in Japan at Keio University. They actually have an upright CT scanner. We don't have one in the United States, which is apparently a really difficult thing to put together. So in the supine position, which is what all of our imaging is done in the United States from the CT standpoint anyway, the internal and external jugular veins are maximally dilated. This is the preferred venous outflow pathway of the brain in the supine position. When you stand up, so this is now the upright CT scanner, those veins will naturally kind of collapse, and it's one way that you prevent overstrengthening of blood out of the head. But this is just sort of a pictorial representation of whether you're internal or external, right or left. You know, when you stand up, those that jugular system does tend to collapse. So we also did volume rendering of the blood in those veins. You can see that the jugular system here in the supine position is pretty nice and juicy. But in the upright position, they actually get smaller, and these veins here that are around the spinal cord and brainstem, what we call the paravertebral venous plexus, they get more dilated. What's also important to see is that the arterial system, the vertebrovasor system, actually doesn't change much when you are changing position. That's because your body is going to try to protect arterial perfusion really, with every option that it has. So venous flow is actually tightly coupled to CSF flow, right? So your cranium is the fixed space, the tissue does not change volume too much, arterial pressure is going to be mostly preserved. So if CSF changes, then the only other thing that can change is venous flow and vice versa. And you might not be able to see this, in just regular standing, but you can actually show this relationship with forced breathing. And so this is what this one particular study did with an MRI. So they looked at CSF flow at aqueducts, so like the lower to midbrain, at C3, and also down in the lumbar spinal cord. And they looked at the relationship between CSF flow and venous outflow. And the external one is internal jugular vein. And what you can see is that when the CSF flow goes up, venous flow goes out, and vice versa. So what they're doing is they're sort of keeping this same volume in the head. So they're really, really important partners. So this is really important when we talk about outflow, like obstruction problems and what that might do to CSF pressure, but also CSF clearance. Now, the main drivers of the pulsation of CSF there are actually two things. The first one is a very low frequency pulsation, which goes with respiration. It's about 0.2 cycles per second. And the second one is around 1 cycle per second, and that is the heart rate. So the thing that I think people don't always recognize is how important respiration is to all this circuitry. So 3 venous compression cases. The first one, 48-year-old woman with hypermobility. She has Eagle syndrome, both neurogenic and venous thoracic outlet syndrome, is esplanade. And she presented to me with 16 years of continuous vertigo that was induced by a car accident. She had tinnitus, severe migraines, head pressure. She was not able to lie flat because it would worsen all of her symptoms. She had a globus sensation, turned out to be actually pretty common for this kind of pathology, severe cognitive problems. She also had severe left hand and arm numbness and tingling. Also critical here is that her headache and her dizziness could be worsened with her left arm elevation. So what is Eagle syndrome? This was actually described by Watt Eagle in 1937, so really a long time ago, back when there was no CT and no MRI, it was basically plain x-rays. And he described 2 syndromes, one that we call classic Eagles, which is mostly characterized by throat symptoms, and carotid Eagles, which is mostly characterized by ischemic symptoms. And he said, a little interesting that people have elongated styloid processes. But it turns out that there's actually a 3rd variant called the jugular variant, which is characterized by headache, vertigo, and a lot of CSF pressure type problems. So what you can see in this diagram here, you can see the little styloid process coming off just below to the mastoid. And you can see that if the styloid process were to be a little long, it can impale the carotid artery, or it can get in the way of some of the nerves that are also traveling in that space. This is a radiograph of kind of an elongated styloid process on both sides. This is kind of the traditional way of removing the styloid process, which is a transoral approach. This is actually not the approach that is appropriate for treating jugular variant Eagles, but this is kind of what is done in the world right now. What's really critical to this story is that the length of the styloid process is not important. It is what direction it's going, how thick it is, and what it's actually impacting. And so this is why this field is a complete mess, because because a lot of people were doing, cellular removals, and not really knowing how much to take and where to take it, when to take it. And so kind of understanding, the physiology and all the structures that we need to pay attention to is really important. But look at what these papers started coming out. They started coming out in 2019. So this, so if you're a certain vintage, you might not have heard about this during your training. I certainly did it. I trained in top neuropsychiatrists in the country. We've never talked about Venous syndrome. It's really not. This is actually quite common. And as Dr. Johnson mentioned, it's not the carotid artery, or even the nerves that are vulnerable with this silent process. Compression is actually the vein, right? Because it's just more medium, right? So here's the internal jugular vein that's sitting in between the styloid process and the articulation of the skull with C1. So what happened with this patient? Well, so she had seen a surgeon, and so this is her baseline CT schedule, that she actually has elongated styloid processes. They're about 4 centimeters. In adults, we let them get to about 3, but again, it's not the length, it's actually what is bothering us important. So the ENT said, okay, I know how to treat that. I'm gonna cut you back. And so what the ENTs will do is they will cut the styloid back just to a quote normal length. So he cut her styloid back to a quote normal length. And now there's something about that. Right. So then at that point she was like, okay, now what do I do? And I think we need to actually cut you back to above the point of the compression where we actually free that internal jugular vein. And so she actually went to one of the top surgeons in the country that kind of recognizes this pathology. So he cut her back all the way to almost to the base of the styloid, to above the point of the vein compression and her vertebral vein. So this is her CT again in the same time points. You can see that this was her baseline. This was after the first surgery. That vein is not freed after that first surgery. This is the second surgery. That freed that left vein and the vertebral spine. Now she actually has compression on the other side too, but she's actually going to get that surgery because she still has a lot of head pressure. The second case, again, 39-year-old woman, Ehlers-Danlos syndrome, migraine, a lot of shoulder dislocations from her hypermobility, thoracic outlet syndrome, Heckmeyer syndrome. She started to have vertigo spells about a year before she presented to me, which specifically vertigo triggered by turning her head to the left and lying flat. And this was associated with left eye pressure, facial spasms, and left arm pain and weakness. And as I'll tell you the story, along the way she started to have syncope. We actually treated her medically for a while. She did quite well. Calcium blockers, topiramate, CGRP inhibitors, physical therapy. She did quite well until she started breaking through. So we imaged her. So this is her CT scan showing the left internal jugular vein that's kind of being pushed by that lateral process of C1. This is her right side. It looks, pretty good. And so she, went to physical therapy, and we tried to kind of treat this conservatively. This is actually a few years ago. But then what happened is that she started to pass out, and then she got admitted to the hospital. And this is a patient who couldn't lie flat because she would get vertigo, and she couldn't stand up because she would pass out. So she was in the hospital, and it was a really, really big to-do to, tell people, this is a few years ago, so even now we have some struggles telling the story. It was a really big problem back then. I said, can you, please do a venogram on her? So this is her left internal jugular vein, and you can see that although most of the blood flows down that left internal jugular vein, she has some of that flow going retrograde and some of it going down those tubal veins. When she turns her head to the right, she's actually mostly okay, right? Most of the blood goes down that internal jugular vein. So look what happens when she turns her head to the left. So even if you've never seen one of these before, you know that this is not normal. So she actually has a point compression here. They actually said this is by the styloid process. And she has all this retrograde from up to the brainstem, to the sigmoid sinus, and going down the vertebral veins. And you would think that this would have been an easy sell to the surgeons? No. So they didn't believe this. We actually had to transfer her to another hospital, and there happened to be a vascular surgeon who said, okay, I believe this. He took out her styloid process. She was able to leave the hospital upright. So she did well, and then a few weeks, let me just tell you why you have this kind of vertigo. So when that blood goes back up the skull base, like as in her case, look at where the blood can go. It goes right around here, which is right here. And that trigeminal ganglion, where the sensation to the face is its neighbor, and then the fluid out of the orbit, right, from the cavernous sinus, also goes down the same system, right? And it should be going down in one direction, not going backwards, not going side to side. So, so a lot of times these patients will be diagnosed with multiple syndromes, so they'll be diagnosed with migraine with aura, and they'll be diagnosed with occipital neuralgia, and trigeminal neuralgia, and Meniere's disease, and myofascial problems, and so when you start to see like the laundry list of these syndromes that people have, you have to start thinking like maybe there's an underlying structural problem that kind of ties it all together. So, so one of the reasons why she's so interesting is that she had her vertigo come back after about 3 weeks after the surgery, and she has some redness up her neck. And so like, oh, I hope she doesn't have a blood clot, right, in that vein, because she does have that, side operated on. So I said, okay, let's image you. And so she had actually had this vein compression now all the way down to C5. But she has redness of her skin, so I said, well, let's treat her for some cellulitis. So she got treated and just to really, complete. We imaged her again after the vertigo went away, the cellulitis resolved, and now the vein is back again. So she did okay for a while, Botox and PT, the compression returned. And so this is where we said, maybe we should try some NUCCA. Here's not this thing called NUCCA, maybe we can try this. And so she actually did NUCCA for a good 9 months. And it really helped the frequency, the severity, and the duration of her vertigo spells. And in fact, she was a little bit like NUCCA dependent though, because when she would miss some sessions, her vertigo would come back. And the important thing to remember that this is a person who has hypermobility disorder, right? So she's someone you can just see on her serial imaging that atlas kind of goes back and forth a little bit more than we normally see it in most people. You have to sympathize during one of her NUCCA treatments, and the NUCCA doctor was like, I'm a little bit uncomfortable doing this. And so, so we kind of stopped NUCCA for a while. She actually ended up being treated for Peck minor syndrome during this time. And so, we were doing okay actually for quite a while. You can see that there's kind of a 16-month gap from when we had to do anything new. She had a fender bender, a lot of symptoms came back, we finished her again. It wasn't too bad, at that point. Again, just treating her with medications. And she was getting well enough in that she couldn't fly. But she somehow was in a wheelchair, she fell out of her wheelchair, and then then all hell broke loose. And so everything came back, we measured again. So now you can see not only is this, vein really pinched here by C1, so all this dilation of the suboccipital venous process, what blood is trying to get out of the So she did go back to NUCCA for a bit, but at that point, I said, I think we need a more kind of permanent solution to this problem. So I sent her to one of the neurosurgeons in the country, who's kind of at the forefront of treating these vein disorders. He actually put a stent in her. So this is her pre-stent venogram. You can see actually her shunting is a little worse than it was a few years back. Even in the neutral position, she's shunting quite a bit to bring some into the vertebral column here. For some reason, we had her turn right instead of turn left. But even in turning right, she has the shunting. So we put a stent in her, and the shunting is down, and even with the catcher. So she's actually doing her syncope and her vertigo. Have stopped, so we're crossing fingers at this point. The thing just to kind of keep in mind is that we're all kind of like deteriorating. So I tell people, I don't know, this has sort of been bought some time, but you're still going to have to do your PT, you're still going to have to, this doesn't mean that you can abuse your body, you're going to have to take care of yourself. This is what a stent looks like on CT. The last case would be a much shorter one. This one is actually not a NUCCA patient, but I want to tell you about him because I think you'll see a lot of patients